Hello, everyone, and welcome. Good morning. Oh, well, I always have to say good morning on the West Coast. And one of our guests today, Dr. Saxena, is West Coast as well. So we'll be representing two people from the West Coast. Liz McInville will be here any second as well. So, we're just checking out the hair. It's looking a little crazy this morning, but we do what we can. But welcome, everyone. It is always good to see you all. These are the live streams brought to you by the International OCD Foundation. Yay, Dr. Saxena. How you doing?
Good. Can you hear me okay?
Yes, perfectly. I was telling everybody we have two people West Coasters today. Everybody from the IOCF is always so East Coast, so I'm always excited when we have a fellow 9 a.m.er. So, well, cool. Before I introduce my guest, obviously, my name is Chris Tronson. Myself and Dr. Liz McInville, who'll be here any second, host these live streams every Wednesday. The only Wednesday we're not here is the second Wednesday of the month. That's when we do Research Roundtable with Dr. Abramowitz and Kyle King. And what I love about that live stream is they really go over the latest research, but they do it in a very digestible way. So I love that live stream, and a lot of people have learned, and they said that they've been able to learn in like a capacity that works for them. But every other Wednesday, we're either doing a lunch and learn or an Ask the Experts. And Ask the Experts is when we're going to answer your questions, OCD related. Obviously, with Dr. Saxena today, we'll be able to answer medication questions. We're always telling you we can't answer those as therapists. We'll definitely get you a psychiatrist who is well-versed in the area, and that's what we have today, so we're excited. And then we have a lunch and learn where we pick a topic that you, the community, has really been asking for, and bring on a guest that's a specialist in that area or really just knows that space really well and has them on. So we're excited to have you. Welcome to live streams. Make sure you're here every Wednesday. We also have live streams Tuesday evenings, 4 p.m. for us West Coasters, 7 on the East Coast. We have people like Katie O'Dunn, Ethan Smith, and others that host. There's my much more attractive, better half, Liz McInville. Hello.
Hi. How is everyone?
Good. I was just telling everybody about our Wednesdays. They got to join us each week. We're excited to have Sanj on. So excited. Well, I'm going to read. I want to introduce you to our guest. Obviously, Liz and I are here every Wednesday, but we always bring guests. We love to bring on guests that really have their pulse on the community, really have answers for y'all. And so we're really excited to have Dr. Sanj Saxena here today on the live stream. So he joined the IOCF in December of 2023. He now serves as the liaison to the IOCF scientific and clinical advisory board, known as the SCB. He represents the IOCDF to the broader clinical and research community. He oversees the IOCDF research grant program and assists the staff with conference planning and communications. Dr. Saxena previously served as director of the UCLA OCD Research Program and director of the USC San Diego OCD Program. He has been elected into Best Doctors in America and US News and World Report's America's Top Doctors. So congratulations, of course. His research focused on the neurobiology and treatment of OCD and hoarding disorder. He and his colleagues developed the DSM-5 diagnostic criteria for hoarding disorder. So welcome, Sanj. It's good to have you on the show.
Thanks so much for having me. Good to see you, Chris and Liz.
I know, Liz, I always feel like I do so much, and then when I have our guests on and they have stuff like that, I'm like, oh, back to the drawing board.
Here we are. We're just here. Right. We're so excited to have you. So what I will say is that, Dr. Saxena is a leading expert in the OCD field, and we're really excited because we always get medication questions, and we always say, well, we can't answer those, but we'll have someone on soon who can. So we know we can answer those today. But what I'm really hoping, and that I was talking a little bit about, is that today we'll kind of start, if it makes sense for you, with really laying the groundwork of where we are today, in the sense that what is the recommended treatment for OCD, both behavioral and medication? What are the medications that people should start with? What do we know is effective, right? We'll kind of start there, and Chris and I will help guide and answer those questions. But I think it's really important for us to say, okay, we're in March of 2024. Let's kind of level set around where we're at. What are some updates? What's some emerging, exciting stuff coming on? And what are things that maybe are effective, aren't? I get questions all the time. So if it's okay, we'll just kind of hop in. So Sanj, why don't we start with, if you just want to introduce yourself and a little bit about why you do this work and why you love OCD and anxiety and all of the above.
Sure. Well, so as Chris mentioned, I just joined the OCDF staff as director of research and clinical affairs for the organization. But I've been involved with the organization for 25 years plus, and my interest in research and teaching and clinical work with OCD, hoarding disorder, and relating disorders goes back a very long time. So this is kind of what I've been focusing on for nearly all of my career. And there, we can spend hours listing the reasons why we're involved with the ISCDF and why I think that's really important. So I'm delighted to actually be more on the inside rather than just as a member of the scientific advisory group.
I, for one, feel like we're so lucky to have you. I mean, one of the things that we really wanted was somebody that could sort of be the liaison between the foundation, the community. I think one of the things that's great as well to have you on today is, I think a long time ago, people didn't really know like the ins and outs of the foundation. They always felt like it was this like building of the, up on the sky that wasn't accessible. But I hope what people realize is like people like Liz and myself who have OCD, who treat it, but people like you, experts that have done the research, really laid the groundwork for the DSM, are part of the foundation, and that you're approachable and people can ask you questions and really understand information. So the foundation is beyond lucky to have you. So we're glad to have you both on the stream, but the foundation as well.
Yeah. And I think too, Sanj, it's just, I love, one thing I'll say, just as I've gotten to know you, is I love the way that like you always let research and evidence guide the information that you're putting out. And so I would love for us to just start with that, a little bit of a quick background around like when folks are diagnosed or when they've had a diagnosis for a long time and they're trying to figure out like what treatment is for me, like what should I do, what should I not do, like how do individuals, like consumers, patients, family members with OCD, how do they navigate understanding what the evidence and research shows us? So like what does evidence-based care mean? How does somebody from non-research community, right? How do they make sure that the treatment they're receiving is the right treatment and the treatment that is going to have the highest chance of helping them?
Yeah, those are really important questions. And unfortunately, as we deal with on a daily basis, there's a great deal of misinformation out there. And also just a great deal of lack of knowledge and ignorance about what OCD really is, about how best to treat it, what are the most reliable and valid and evidence-based treatments, even amongst treatment providers. There's confusion because they don't always necessarily get good education in this area. And so it's vital. And, one of the things that people with OCD, family members, parents, loved ones, and clinicians can do is to use the ISCDF's website as a resource. We're currently in the process of doing an update to our treatment guidelines. But the existing treatment guidelines are there on the website. I think there's a section called How is OCD Treated? And it kind of briefly lays out in lay language, what the primary treatments are. And we'll be elaborating on that to a much greater extent over the course of the next several months to really put in a lot more detail and a more sort of formal treatment algorithm. But it's fairly straightforward. There are really two frontline treatments for OCD that have been proven to work well over the last 40 years. There are other sort of secondary or alternative treatments that appear promising, but they have nowhere near the same evidence base as the two frontline ones. So the two frontline ones are cognitive behavioral therapy, specifically using the technique of exposure and response prevention. And I know, Liz and Chris have talked about that quite a bit in other live streams and in other venues. And then medication treatment. And the medication treatment, there's really only one class of medications that is frontline, and there are other medications that are secondary. They are booster drugs or add-on drugs. The frontline class of medications that works for OCD is called serotonin reuptake inhibitors, or SRI medications. And there are several of those. There are about 6 or 7. They all work roughly equally if you look across the population, but a given individual might respond better to number 1 versus number 2 versus number 3. So sometimes we do switch around. They differ more in terms of their side effect pattern than in terms of overall efficacy if you look at across studies. But those are the 2 first-line places to start. And for most people with OCD who we see in a clinical setting, they're going to do best with a combination of exposure and response prevention and related associated forms of CBT, as well as medications. If you look at practice guidelines, the approach of choice for people with mild OCD, for kids with OCD that's uncomplicated, that doesn't have a lot of coexisting disorders, or for people who either cannot tolerate the medications or have intolerable side effects or refuse medication, would be exposure and response prevention. The treatment of choice for people who don't have access to qualified CBT with ERP, who don't have the wherewithal to be able to afford it, who maybe have cognitive deficits and can't really follow the instructions or have some other barrier that prevents them from being able to do CBT, then medications are the front line. For everyone else, so for anybody with moderate OCD or more severe, for anyone with OCD who has coexisting disorders that also would respond to medications as well as therapy, the combination approach is really best. And if you look long term, people have the greatest degree of response and the greatest likelihood of improvement if they have combined treatment with CBT as well as medications.
So I have a question for you that just to kind of piggyback on this, and is, how does it work when someone starts an SRI? First and foremost, I think it's important to just talk about the difference between an SRI versus like a therapeutic dose for OCD of an SSRI or SRI. Can you talk a little bit about that? And then how long should they expect before they see results, right? I have some folks that are like, I tried it for a week, it didn't work. And maybe they weren't on a therapeutic dose or they didn't give it enough time. So would love to have some kind of ground rules on that.
Yeah, no, that's also a really important thing. And this is what we try to educate parents, families, patients, and clinicians about. So as you pointed out, SSRIs can be given at different doses. The medications that are frontline treatments for OCD are also frontline treatments for many other conditions, including depressive disorders, other anxiety disorders, and so on. However, the doses and duration that are required for effective treatment of OCD symptoms is different. So the doses that are required for treatment of OCD are 2 to 3 times higher than that for depression or for, let's say, generalized anxiety disorder. The duration of treatment also needs to be longer. To really have a full trial of one of these medications for OCD, you need to not only be at a target dose that would be in the effective range, but also be at that target dose for a minimum of 6 or 8 weeks and a total trial of up to 10 to 12 weeks. And that's because the pace of improvement may be slow. There are some people who get an early response in the first couple of weeks, and that is predictive of a better response in the long term, but not everybody does. Sometimes it takes a while to even get up to a therapeutic range of dose, and then it may take a long time to actually notice a real improvement in symptoms, which then builds over time. So for that reason, there are a lot of folks, as you mentioned, Liz, that will say, oh, I already tried that, it didn't work. And what you find when you do a good history is that either they had a dose that was too low or a duration that was too short, or both, right? And this happens very frequently because, unfortunately, primary care doctors and even other psychiatrists and nurse practitioners don't necessarily know the details of the dosing and the duration. So I'll give you an example. I could just list the frontline SRI medications that have either obtained FDA approval for treatment of OCD or have been found effective in controlled trials, and they may have approval in other countries, even if they don't have approval in the United States. And it's the most commonly used antidepressants that most people are aware of. It would be fluoxetine or Prozac, sertraline or Zoloft, escitalopram or Lexapro, citalopram or Celexa, fluvoxamine or Luvox, and then one that's in a slightly different class, an older medication called clomipramine. The old brand name was Anafranil, which is in the class of tricyclic medications, but it's the only one of many tricyclics that is a very, very strong serotonin reuptake inhibitor. So they all share that property in common, is that they are strong serotonin reuptake inhibitors, but they're not necessarily selective. The acronym SSRI for selective serotonin reuptake inhibitors is a little bit of a misnomer because they're not truly selective. I mean, I think, escitalopram or Lexapro is probably the most selective, but most of the other ones also hit other receptors, and they have other pharmacological properties besides just serotonin reuptake. But that seems to be the mechanism in common across that whole group. So, for example, I forgot paroxetine, which is Paxil. So that's the other one, maybe about 6 of them. So a typical dose for treatment of major depression, let's say, with escitalopram might be 10 to 20 milligrams a day. The dose that's required for treatment of OCD may be 30 to 40 milligrams a day. For fluoxetine or Prozac, a typical dose for major depression or generalized anxiety disorder or panic disorder might be 20 milligrams a day. For OCD, it might need to be 60 to 80 milligrams a day. So 2 to 3 times higher. And there are published dose ranges that show what the effective therapeutic range is, if tolerated, for each of these medications. Generally speaking, we want people to be in the therapeutic range for at least 6 weeks out of their full trial to really know if it's going to get benefit. And the full trial, as I said, usually has to be at least 10 to 12 weeks. So if somebody, I'm sorry, go ahead.
Oh, go ahead.
Well, I was saying, so if you start with one of those and the side effects are not tolerable, you can switch, right? So if one of them is too sedating and somebody's feeling sleepy and tired all the time, even if they're taking it at nighttime, it's having daytime carryover effects, you switch to one that's more activating. If you start with a more activating one and it turns out that the person has agitation or insomnia and their sleep is disrupted, you switch over to one that's more sedating. And they vary in other side effects as well. So we do switch around sometimes, but we do want to make sure that we get to the highest tolerable dose to get us into the therapeutic range for a long enough period of time.
This is so helpful. And so many people are asking questions, and as they've been putting them, you're answering them. So it's great because I'm like knocking them off all at once. You are reading people's minds. But this is really important. And I love the idea too that we need a therapeutic dose for a prolonged period of time before we can say it works or it doesn't. I also love that if side effects are happening, you can think about which, like, I love the example of like, this one's making you more agitated. Okay, we'll give one that actually may make you, like, there's ways to augment that versus just saying, oh, SRIs don't work for me. It's like, well, maybe that SRI didn't work for you, and we shouldn't necessarily jump to that. So that's my next question is, what is kind of the guidelines and the rules right now, for, like, up to date as can be, for how, if an individual tries an SRI at a therapeutic dose for the full length of time and it isn't working, or they don't feel like they're getting the benefits they would like to see, are you changing to a different SRI? Are you augmenting with a different medication? Like, what are the next steps if that first
trial is insufficient?
Most important step, but the first recommended step isn't efficient.
Right. And again, these are very important questions because many people don't get an adequate or sufficient response. So it's important to know what the expectations are. The state of the art of sort of first line single medication treatment of OCD is not necessarily as good as it is for some other conditions where you expect a greater degree of response maybe from the first drug or the single drug. With OCD, the average degree of response if you look across all individuals who might be trying a particular medication at a full trial dose is about maybe 30-35% reduction of symptoms in folks who'd be classified as responders, the average might be, closer to 40% or maybe 50% reduction of symptoms, but only about 40 or 50% of all people who try a given drug will have that degree of response, right? Would be classified as responders. Now that's still significant. That's a noticeable difference. It's clinically significant. And we're looking not only for improvement in people's symptoms, but also improvement in their overall functioning and hopefully ability to accomplish their tasks, continue their education, and improvement in the co-occurring disorders. So we'd be looking for improvement in co-occurring depressive disorders, co-occurring anxiety disorders, and so on. But even with a full trial at a full duration, the expectation is, okay, maybe someone is going to get what we'd consider a partial response, maybe 40% reduction of symptoms, 50% if they're lucky. A lot of folks have less than that, maybe only 20 or 30% reduction of symptoms. So then the choice point comes, as you talked about. Should we try to boost that response by adding on a secondary drug, an augmentation, or should we switch and try a different primary one? And that is an individualized decision that has to be made by the physician and the patient. And it depends on a number of different factors. It depends on whether the dose of the first one is being limited by side effects, so you're not really getting a full trial. And it depends on the degree of improvement. So, generally speaking, if it's anything less than about 20-25% improvement, I would consider that a failed trial and just switch to a different one and see if we can get somewhere, with another SRI, or moving from a more selective one to a less selective one like clomipramine, we can get a better degree of improvement in that same person. If we're getting a partial response, let's say it's 25 to 40 or 50% reduction of OCD symptoms, but there's still a long ways to go, then we consider augmentation. Now, by far the most important augmentation is combination of medications with CBT, specifically exposure and response prevention. So that's the combination treatment that I was talking about before. That gives you the greatest likelihood of response and the greatest degree of improvement statistically across averages. But there are also classes of medications that have been found in randomized controlled trials to be effective secondary drugs or augmentation or boosters. There may be 3 or 4 or 5 different classes of those. And those we will use to add on, let's say, one, if we have a partial response with the first medication, we don't want to lose that. Let's say we've tried a couple and we're picking the one that has the greatest response, but even that one has only produced a partial improvement. Or maybe it's been effective for the other coexisting disorders. So let's say that the person has depression or another anxiety disorder along with their OCD, and that actually has gotten better with fluoxetine or sertraline or escitalopram. And so you don't want to lose that positive effect, because those co-occurring disorders can also be very, very severe and disabling at times. But you haven't had enough improvement in the OCD, then you would want to add. So the classes of medications that have been found to be effective as add-ons or augmentations would be, number 1, atypical antipsychotics. And that's actually a misnomer as well, because these medications are actually used much more frequently for other disorders, including treatment-refractory OCD, treatment-refractory depression, treatment-refractory anxiety disorders, than they are used for what they were originally designed for 20, 30 years ago, which was treatment of psychotic disorders. And so these are non-specific drugs that have effects on a lot of different disorders in a lot of different ways. So, for example, the 2 that are probably most frequently used as add-ons for treatment-resistant OCD would be aripiprazole, or it's called Abilify is the brand name, or risperidone, Risperdal. The evidence for those 2 seems to be greater than for the other ones. There is some evidence in favor of medications like olanzapine, which is Zyprexa, or quetiapine, which is Seroquel, but the studies were mixed in those ones. If you look at large-scale meta-analyses that compare across lots of different augmentation strategies, the 2 that seem to have the best effect size, the greatest likelihood of response, and the greatest degree of response would be aripiprazole or risperidone. That doesn't mean that there's nobody who would respond to the other ones. There are some people who would respond preferentially to the other ones. This class is also pretty heterogeneous. Even though they're all grouped together in the same family, they're clearly not identical. And sometimes people do respond much better to one than the other. So again, we have to potentially do some switching around and trying different augmentations based on side effect profile as well as overall efficacy. Another class of medications that's been found to be effective as add-ons are mood stabilizers. So there's some evidence for lamotrigine or Lamictal, which is a mood stabilizer used for bipolar disorder. It's also an anti-epileptic or anti-convulsive drug used for epilepsy and a few other neurological disorders. And then some evidence for topiramate or Topamax, but those would be probably a little bit lower down on the list. Another category of medications or family of medications that's been found to be effective as augmentations are the serotonin 3 receptor blockers. These are medications that are used primarily for gastrointestinal disorders. They're used as anti-nausea drugs in cases of bowel disorders or for folks undergoing chemotherapy for cancer who have a great deal of nausea or other, GI-related conditions. So these would include ondansetron and granisetron, and I think there's a third one as well. They're all in that same category. A lot of psychiatrists and psychiatric nurse practitioners are not aware of that class of drugs, but it's actually easier to use. It has fewer side effects. The one main side effect that it can cause would be constipation, but it doesn't have some of the other side effects that scare people off from using the atypical antipsychotics. And those can be equally effective as add-ons. A fourth class that has been receiving a lot more attention, it's generated a lot more excitement over the last, let's say, 5 to 10 years, are glutamate modulators. These are all medications that affect the transmission of glutamate, which is the most important excitatory amino acid transmitter, a neurotransmitter in the brain. And it's one that's been found to be heavily involved in the physiology of OCD. There are a number of different medications. Memantine or Namenda is a drug that was originally developed to treat dementias, including Alzheimer's disease. But it also has other effects on the glutamate system that do seem to be helpful for OCD as an augmentation. So there's been a number of controlled trials that have been found in which memantine has been superior to placebo as an augmentation. There are some evidence, although it's mixed, for an over-the-counter supplement called N-acetylcysteine, or NAC. It's not FDA regulated because it's marketed as a food supplement, some studies were favorable, some studies weren't. There's another one called amantadine that has very little evidence. I think there's only 1 or 2 trials showing efficacy, but at least it was promising. And then there is ketamine. And ketamine has received lots and lots of attention because it has been found to be a rapid-acting antidepressant medication and sometimes effective for people with very severe and treatment-refractory depression. And it's been found to have effects on suicidality. So there are ketamine clinics that have sprung up all over the country, all over the world, because sometimes people can get very rapid improvement in depression symptoms. There have been only 3 studies that I'm aware of, 3 controlled studies, and some case series before that, but 3 controlled studies for OCD. 2 of those studies were in people with OCD who did not have major other comorbid depression or other disorders. And those are studies done by Carolyn Rodriguez and colleagues at Stanford, and they were positive. So IV ketamine infusion was superior to IV placebo or saline solution, and did produce fairly rapid resolution of symptoms that was noticeable within a few hours. So IV ketamine, when it works fast. The degree of response is kind of similar to what you see with other medications for OCD. So again, we're looking at maybe 30, 40, 50% reduction of symptoms. None of these medications are ones that are likely to produce, 90 or 100% reduction of symptoms. If we get that, we're extremely lucky, because it's rare. Most of the time, what we can expect is a significant improvement, but not necessarily complete remission just with medication alone. That's where you need the combination. So the third ketamine study was in people who did have depression and OCD together, and that study was negative. The OCD symptoms didn't improve in that group. So again, the jury's still out. Initial studies, at least in OCD alone, look promising, but it's very, very preliminary because, again, there's only a couple controlled studies. And now there is a good deal of research on other sorts of glutamate-related medications. There's been a trial of Riluzole that was plus minus for OCD, a newer drug that was developed and is currently being studied in another phase 3 trial is called Troriluzole. The initial phase 2 study was done a few years ago. I was actually one of the sites for that at UC San Diego, and the results were sort of plus minus. It was a little bit better than placebo, but it wasn't significantly better. There were subgroups that seemed to respond. So now they're modifying it. They're changing the criteria a little bit and changing the dosing pattern to see whether in the subsequent study that's underway right now, for which they're still recruiting, whether they're going to get an effect. Even if that one doesn't work out, I think there's a good deal of development in pharmaceutical companies of other glutamate-related drugs that affect the transmission of glutamate or affect glutamate receptors in a variety of different ways. There's also development of other drugs that affect serotonin in different ways too. People are more familiar with that because those medications, SRI medications, have been around for 30 plus years. But that's not the only neurotransmitter involved. And
Right.
it's probably a combination of different things acting on a number of different circuits in the brain that produces the desired effect for OCD.
So here's kind of what I'm hearing, and I want you to correct me if I'm wrong, but I'm hearing that like SRIs are much like ERP. So like ERP for the behavior. So we know for OCD, the gold standard, right? The most common and effective intervention is a combination of medication and behavioral therapy. What we know for behavioral therapy is that ERP is first line, right? That is really like the most studied, the most effective. It's really what you should be doing first,
Right.
and what you should be hoping is going to make the biggest difference. I always tell people with ERP, very similarly to what you just told us about medication, is that just because you try ERP once doesn't mean it doesn't work for you. Maybe it wasn't the right dose, right? Maybe you need a higher level of ERP. Maybe you need to change your level of care. Outpatient isn't what you need. You need a day program. Day program isn't what you need. You need residential. Maybe it wasn't the right therapist, right? They didn't understand kind of how to do ERP effectively. So we definitely shouldn't just say, oh, tried it once, doesn't work. And I'm hearing the same thing with medication, right? It's really like SRIs are the primary thing we should do. And if the first SRI isn't working, we should figure out, are we on a therapeutic dose? Have we given it enough time?
Mm-hmm.
Is there another SRI that we should think about? But then there are some augmenting medications that doesn't mean you throw out the SRI necessarily. It's that you're doing those with the SRI. And then those can
that's an important point, is that those different classes that I was mentioning, the 4 or 5 different classes of augmentations, don't work by themselves for OCD. They are often effective for other disorders. The atypical antipsychotics are used primarily for schizophrenia, other psychotic disorders, bipolar disorder. But if they're used alone, they're not effective for OCD. The glutamate modulators may be effective for other disorders. The anticonvulsants like lamotrigine or topiramate may be effective for bipolar disorder or epilepsy, but by themselves, they're not effective for OCD. These have been only found to be effective when they're added on to a full dose of an SRI. And usually at doses that are lower than what would be used if you were using them by themselves for one of those other conditions.
Right. Okay. So helpful. I really love breaking that down. Can we hop to ERP for a second as well? So can we kind of go over to OCD behavioral treatment? And would you say that ERP falls into that same mold, that really like what I was just saying? So ERP is the front line. That is really what we should be doing first. But then there are interventions like ACT, right? Where we know that ACT can be a really useful treatment if it's used in conjunction with ERP. It can really kind of bolster, increase those effects. And so maybe sometimes people are using ERP plus ACT or ERP and DBT if that's needed for them, and they have a comorbidity that really needs some DBT specific skills. Anything else? And can you talk a little bit about, from the behavioral side as well, what research shows us right now we should be thinking about? Because a lot of people are talking about it. I just want to throw that out there, Chris, that one of the biggest questions we get is like, well, what about ICBT? What about these other interventions? Like, why aren't we pushing those? And I'm always very clear that like, I'm happy to push them when the research and evidence shows that they measure up to ERP. It doesn't mean they won't. Like, I'm not saying that's not going to be the case, but as of right now, that isn't the case yet.
Right. And so let me you brought up a number of really, really important points that I want to and, and we could do an entire other show on reasons why treatments may appear to be failing, and reasons why a particular strategy didn't seem to work, and going through all those different things, the amount of therapy, the amount of intensity, whether the therapist really understood, whether the diagnosis was accurate in the first place, whether there was another factor that interfered, like substance abuse or severe depression or PTSD. There are a lot of things that can get in the way of a particular treatment working. That doesn't mean that that treatment wasn't the right treatment. It means that you have to deal with those other factors, and you have to make sure that the treatment is presented and delivered in a way that's going to be most effective for that person. So let me address a couple different things. Number one, we talked about other treatments as augmentations. And you're right. So just as you can augment SRIs with other classes of medications to boost the effect, you can augment ERP. Sometimes we will use more traditional cognitive restructuring strategies as an add-on to ERP, specifically for people who have poor insight. Or maybe lack insight, and so they really believe their OCD beliefs, and they're not willing to do exposures because they really think that something terrible is going to happen if they don't do their ritual. And then before you can actually get them into doing effective exposure and response prevention, you first have to improve their insight and motivation. So motivational interviewing procedures, and for the insight, really addressing distorted beliefs or delusional level beliefs about the content of OCD, to work on those with cognitive restructuring. You can augment with ACT, you can augment with mindfulness, you can augment with DBT. All of those have been studied in controlled studies and been found to be effective for subpopulations as add-on treatments. Again, they haven't been found to be effective on their own. DBT,
I want to like ring a bell for a second, just because it's so important, right? It's so important that we like are thinking about the fact that these are add-ons. And I'm happy to give a quick example about that, but you think about something like grounding. Grounding is a really great mindfulness tool, but if it's used in the wrong context for OCD, it just can become another ritual, right? Or another way to avoid anxiety versus leaning into it. And so it's really about like, this is integrated with ERP.
Right. And so yes, so combining treatments, augmenting, if you've had, a full trial of ERP, or it's not working enough and there's some barriers in the way, you want to address those barriers. And we frequently need to address those barriers with treatments that will either get at coexisting conditions or at other processes that are going on with that person. Let's say they're having a lot of trouble with emotion regulation. That's a situation where you might want to add on DBT, or their depression that's coexisting with their OCD is really severe, so you need to add on behavioral activation or DBT for their depression. Those are just examples, right?
Yeah.
Then let me address another part, which is, well, what about other treatments that could be used by themselves? And what do we mean by evidence-based, right? And these are terms that are thrown around, but a lot of folks don't really understand what we mean by that. And there is a scientific basis and a statistical basis for why certain treatments are ranked much higher than other treatments, right? And when we talk about the quality of the evidence, the quantity of the evidence, the robustness of the evidence, the effect size, all of those are terms that are used in clinical trials methodology, in meta-analyses, and by groups that create treatment guidelines, practice guidelines, and ratings of the effectiveness of different treatments. So let's take ACT and ICBT. There are a handful of randomized controlled studies of ICBT and maybe 6 or 7 with ACT that showed that they could be effective even as sole treatments for OCD. But they compare to probably 30 or 40 randomized controlled studies of ERP. And they haven't necessarily been done in the broad populations. ERP has been studied all around the world in multiple languages, in multiple cultures, been delivered with literally millions and millions of people by hundreds and hundreds of thousands of therapists all across everywhere. It's been studied in children, in young adults, in middle-aged adults, in elderly people. Every conceivable comorbidity, every conceivable symptom dimension or subtype of OCD, in every potential combination with medications, either prior to medication, simultaneously with medication, as an add-on to medication, used for medication tapers. There are long-term relapse prevention studies, sort of every different kind of study that you can think could be done of a psychotherapy has been done with ERP. In addition to those 30 or 40 randomized control trials, there's a huge number of case series and open trials, even more than that, and probably over 1,000 articles over the course of 40 years investigating and researching its various mechanisms. So predictors of response, moderators of response, mediators of response, predictors of poor response, all kinds of different mechanistic things, looking into the basic mechanisms by which ERP works. So studies on fear extinction and studies on inhibitory learning, all different sorts of aspects. So just as with medications, there are probably 30 plus studies just of SRI medications for OCD. Again, placebo-controlled studies, not even counting the open ones. And these studies are rigorously controlled. And what you find in a lot of the other psychotherapy research is that it's not necessarily all that well controlled. Many of the studies, unfortunately, even including studies of CBT and ERP, allowed medication. So they're not really studies of ERP by itself. They're actually studies of ERP added on to medication, right? And that's been true of a variety of the ICBD studies were like that. Some of the ACT ones were like that as well. And they didn't necessarily control for dosing of medication that the person was on, how many medications the person was on. Not all of them control for coexisting disorders and which ones are present. And so there's a lot of variability across studies. And so there are ways of ranking whether a study has really, really solid evidence or doesn't, based on how well controlled it was, how large it was, how broad the population was. Was it just, a specific age group and a specific subpopulation of one ethnicity in one area, or is that treatment broadly generalizable and it's been found to be effective in a whole variety of cultures and languages and ethnicities and delivered by different sorts of people in different circumstances, right? That has to do with the robustness of the data and how substantial it is. So when we compare ERP to basically any other therapy that's been studied for OCD, there are probably up to 10 times more controlled studies with 10 times as many patients, and probably more than 10 times as many other studies that investigate the basis of it and the mechanisms of it and all those different aspects of it. No other therapy has that body of research, just as no other medication class has the body of research that SRIs have for OCD, again, over close to 40 years now, and all different sorts of pharmacological methods, brain imaging studies for CBT and for SRI medications, and for some of the augmentations. There's no brain imaging studies I'm aware of for other treatments for OCD, other therapies for OCD of ACT, mindfulness, DBT, ICBT, and so on. So it's not only the number of studies, it's the type of studies, it's the breadth of the studies, it's the breadth of the populations, it's the real world experience, right? Of, again, literally millions of people over many, many years with medications and with ERP. A lot of psychiatrists will tell you, you don't really know what a drug is going to do and how well a drug is going to work just from the research studies. You really have to actually have it out there in the field being used in real world situations in lots of people who would have never qualified for the research studies because they're too complicated or their illnesses are too severe, to see what the real effect is. So there are things that look good in controlled research trials that end up not really panning out in the real world. And that's why certain classes of medications are used more than others. It also goes the other way. There are sometimes things that didn't look good in the research studies, but actually we find subpopulations in the real world, in naturalistic settings where those medications clearly do work. And then the literature sometimes catches up with that later. So there's all different ways of doing this. But when we talk about front line, what we mean is that it has the strongest evidence base. It usually means also that it has the biggest evidence base by far, the most long-lasting evidence base, the greatest degree of response, the greatest likelihood of response, all of those things.
Totally. And I know we've got a lot of questions, so we're going to hop into some of those in a second. And if it's okay, Chris, I love to do this. And sometimes it can feel hard for us to say yes or no's, but like these rapid fire answers. Because I actually have somebody today that was like, Liz, I need your advice on deep TMS. And I'm like, okay, like, do you want my long version or short version? But like, let's kind of do that a little bit. So what we know is that number one, SRI is number one ERP. TMS, effective for OCD or not?
It can be. So TMS is one of the what we call neuromodulation treatments. It includes transcranial magnetic stimulation, TMS. It also includes some of the surgical procedures like deep brain stimulation or neurological surgeries for OCD. All 3 or 4 of those neuromodulatory methods are used kind of as third or fourth line treatments only for people who haven't responded well enough to combinations of medications and ERP, including intensive treatment.
Okay, so that was my big question.
Yeah.
So TMS is a maybe, like could be. Wouldn't be first line, but it could be something you would try.
Right, and the studies, there've been a number of studies. There's probably a good 10 plus, maybe 15 controlled studies of TMS from all over the world, just as there at least 10 plus controlled randomized controlled studies of deep brain stimulation from all different countries around the world, and they do work. And in fact, some patients will have a good degree of response, but because of their other factors and because things like TMS are temporary treatments. So with TMS, it was modeled after ECT, which is electroconvulsive therapy. We knew for, again, decades and decades that electroconvulsive therapy was a terrific treatment for really treatment refractory and really severe major depression, potentially the most effective treatment there was, but it didn't last very long. People can get better with ECT, but then they may relapse if they don't have some ongoing treatment, either medications or maintenance ECT. Transcranial magnetic stimulation was a way of getting the same effect without delivering the electrical pulse that produces a convulsion or a seizure activity in the brain. And it doesn't require anesthesia, right? So you don't have to have general anesthesia and all the other factors that make doing ECT a little harder. And so it was developed as a good treatment for refractory depression, but in the same patients. Those who hadn't responded well to combinations of medications and combinations of therapies and usually were in a hospital setting because they hadn't responded well or their symptoms were so severe. And it was found to be effective there. Then it started being developed and tested for other conditions, including OCD and other anxiety disorders. So the evidence base in OCD is not nearly as great as it is in depression. The studies, most of them show superiority to what's called a sham stimulation, but not all. And the degree of response is not necessarily as good. But most importantly, it's still a temporary treatment. So the effects wear off. There might be a course of TMS that somebody might do. They might have 3 to 5 treatments per week for, let's say, 5 or 6 weeks. There are accelerated forms where they do a number of sessions per day and a greater number per week, and you can get an effect in a shorter period of time, maybe a matter of days. Nevertheless, it wears off. So you have to find some maintenance. And that's another reason why a treatment like TMS isn't considered a frontline treatment, because number one, it hasn't been compared to medications. It's only been used really in people who are refractory. And the percentage of people overall who respond to it is probably not as great as who would respond to ERP or to medication. So it's used for people who didn't, right? The same with deep brain stimulation. Because it's a surgical procedure, because you actually have to implant electrodes in the brain, it's going to be reserved only for that small percentage of people with OCD who really have not responded to intensive treatment in combinations of medications and psychotherapies.
many failed stuff.
Yeah, there was a question by Mindy at 1228. If you want to put that up on the screen, Amanda, she asked about SNRIs. I don't think we talked about that. So SNRI, is that something that we find effective for OCD treatment?
Yeah, so it's a good question. So SNRI, that acronym refers to serotonin and norepinephrine reuptake inhibitors. And that is a related class of medications. They're a little bit different than the somewhat more selective SSRIs in that they have a greater degree of effect at two different neurotransmitter systems. So they're working both on enhancing serotonin transmission in the brain as well as enhancing norepinephrine transmission in the brain. And they include, I think there are 3 of them that are on the main US market. Venlafaxine, which is Effexor, duloxetine, which is Cymbalta, and desvenlafaxine, which is Pristiq. And actually, there is a 4th one, but it's not used that often. It's called levomenalcipram or Fetsima. These different SNRIs have sort of different ratios of serotonergic effect versus norepinephrine effect. So, for example, venlafaxine and desvenlafaxine, Effexor and Pristiq, are kind of roughly 3-to-1 potency for serotonergic effects versus noradrenergic effects. As you increase the dose, that ratio changes. So a lot of times you get more norepinephrine effects as you get up to higher doses, and you start getting even into some dopamine reuptake inhibition. These medications that hit a number of different neurochemical classes are pretty effective antidepressants. As treatments for OCD, they're probably 2nd or 3rd line. The evidence for each of them is mixed. So there have been at least, I think, 3 or 4 randomized controlled, placebo-controlled trials of venlafaxine for OCD. They weren't all positive. I think maybe 3 of them were positive, and there were probably 2 that were negative. With desvenlafaxine, there's really only been 1 or 2. I think there was a comparison trial with paroxetine that showed that desvenlafaxine or Pristiq was as good as paroxetine, but I don't think there was even a full placebo-controlled trial. So the evidence is pretty minimal. For duloxetine, there's a controlled study of using duloxetine as an augmentation, and it was effective in some people. There is, I think, a small controlled trial for refractory OCD of using it by itself, and it looked good, but that was a very small study. And so the evidence base for those is a lot smaller, and it's not necessarily all positive. So we reserve those medications as alternates, as sort of 2nd or 3rd line monotherapies. You wouldn't use them as an augmentation. You could potentially use them as a monotherapy or single medications if somebody hadn't responded to, let's say, 2 or 3 trials of a more selective agent or of clomipramine. Clomipramine also, it could be described as like an SNRIs because it hits both serotonin and norepinephrine reuptake, and it also does a variety of other things. But it's the only one for which there's really, really strong evidence from multiple placebo-controlled trials over a long period of time. That being said, I've certainly had patients who I needed to switch over to Effexor, let's say, or switch over to Pristiq because the more selective ones didn't work, and some of them did respond. And sometimes they had a better response in terms of their co-occurring depressive disorder or one of their other anxiety disorders. So there was a reason to switch and then maintain treatment on Cymbalta or with venlafaxine. But because the evidence base isn't anywhere near as strong as it is for SRIs, we would not use these frontline unless the person had already tried the more selective ones, or they couldn't tolerate the side effects of the more selective ones, or there was some major factor that required using the SNRI.
I wanted to ask real quick, Dr. Saxena. So one of the things is, like, obviously when I was going through treatment, things were a little bit more clear. It was like, okay, you're going to start on an SSRI, you're going to stay on it for a couple months so we could see if it's working, and then switch over or maybe add an adjunct. And on the therapy side, it's like, we're really going to focus on ERP. There's obviously going to be some other things, but ERP is going to be the base. I think a lot of people are excited. You're talking about TMS, you're talking about augmentation, you're talking about ACT, DBT. What I worry about, I'm excited. It's weird. It's like a catch-22 for me because I'm so excited. There's new things out there. We have to continue to come up with new stuff for people that are just not responding right away. And I get nervous that people will try, whether it's a medication. What I'm hearing a lot now, for instance, is like I'll have a client who tries a medication for a couple weeks, doesn't think it works, and he's like, oh, I'm reading about psychedelics in South America, I'm going to go down and try it. Or like Liz was saying, both Liz and I obviously run higher levels of care, and I'll have clients that have like ARP doesn't work, and then we're able to do an IOP together, or Liz obviously in a residential, and they soar and they're doing amazing. So how do we both support upcoming research? First of all, I just want to say I love that we've been talking about like, let the research guide us. This is not our opinions. We don't sit around and pick what therapy we think sounds cute. It's really guided by science, right? But how do we as a community both be excited about new stuff, but not let it feel like the Wild West where we're just having people try here and there and they could be missing these really frontline medications and treatments?
Yeah, I mean, those are all, again, really important points. And that's why I wanted to spend some time earlier discussing what we mean by evidence-based and why certain things are frontline and other things are either novel or experimental or would be considered sort of alternate therapies only if full trials of the frontline ones hadn't worked. And again, it has to do with the amount of evidence, the extent of evidence, and the degree of improvement. So, you're right, people have a tendency to chase after the shiny object, right? If some new study on psychedelics gets publicized, it looks wonderful and people want to try that rather than sticking with the tried and true. And if they go to their physicians, if it's a responsible physician, what they'll tell you is that, great, it looks promising, but we are years away from any of those being FDA approved for treatment of the disorders because the bulk of the evidence just isn't there yet. The studies are so preliminary, they're so small. Psychedelics for OCD, for example, there's no published studies, randomized controlled trials. There's an old open trial from Francisco Moreno and colleagues in Arizona that was published like in the late 90s. After that, there were no other published studies of psilocybin in OCD. There are 2 randomized placebo-controlled trials ongoing right now, but they're not even complete yet. We don't even know what the results will be. So it looked promising from one open trial, and that's all there was. The excitement started getting generated because of the studies in depression and PTSD that were more robust, and they have been larger scale, multinational studies looking at the effect of psilocybin and some related psychedelic drugs for refractory depression or for PTSD. And so that evidence base is a little bit more solid, but you can't just extrapolate and say, oh, because it looked good in 2 or 3 studies for depression, that means we'll try it for OCD. Right?
Well, and I just this is so eye-opening to me because I like all the buzz about psychedelics. This is the first time I've heard that there hasn't even been one controlled trial yet that's been completed for OCD. Right. And so it's like, I'm like, wait, what? Like, I thought there had at least been a couple, there just wasn't enough, where I'm like, there hasn't even been one. This is terrifying that we're even talking about it and pushing it right now in different ways that our community at times is. But I also think what you said earlier, Sanj, that I loved is that think about antipsychotics. Like, they can be useful as an augmentation to a SRI, but they're not used alone. And so just when we think or we hear, oh, psychedelics worked for depression or they work for trauma, that and some of our trials might be leading us to really that evidence might be more garnered. That again, even if they are useful for OCD, they may not be useful as a sole intervention for OCD. Right? We don't know yet, but like just be really. And so what I want y'all to hear us say is that there is amazing and incredible evidence and research for treatment that really works for OCD. And majority of the people, over I think 75%, get better with our current most proven treatments. Mm-hmm. That doesn't mean other treatments aren't useful or won't be useful in the future or can't, right? Like it's not one or the other, but what it does show us and tell us is that there is a path you should take first. And that path tends to work for more than majority of folks. But be really cautious also is what I'll say is my warning, and thoughtful of new fads, new promises, new things you hear if they haven't been researched or studied. Because what we also know as advocates, and Chris, I'd love to hear your thoughts as we wrap up, and Sanju too, is that that can be really damaging to individuals with OCD when they hear that there's something else they can do or try that's going to cure their OCD or make them better really quick, and there isn't the evidence, and they go try that and they don't get better, then they think, oh, I can't get better. Oh, treatment doesn't work for me. When oftentimes, I mean, you guys, I run one of the few residential programs. So many of our patients come, they haven't had the right treatment or the right dose of treatment. Many of our patients come and they've had ERP and it hasn't worked, but they've never had ERP in an intensive level, and that's what they needed due to their severity. And all of our, like the outcomes, like our program, patients leave with an average YBOC score between 15 to 16, right? That's kind of the clinical cutoff or diagnostic criteria. They're doing great. The outcomes are great with this tried and true treatment.
Yeah, I mean, people ask me sometimes, you know, out of all the OCD patients I've treated over many years, how many did I need to refer to things like deep brain stimulation or TMS or IV ketamine? And the answer is extremely few. It's a tiny, tiny percentage, because almost everybody will respond if you have the right combination of medications and the right intensity of therapy. I mean, so if all these different strategies of changing meds, adding meds, you know, augmenting, adding different kinds of therapies onto ERP, by far the most effective in my clinical experience is just intensifying the ERP. I mean, in my view, because I've worked in outpatient settings, I've worked in partial hospitalization and intensive outpatient settings, I've worked in inpatient settings. My view is that intensive treatment is actually the treatment of choice for OCD. Because you get the greatest degree of response. People who haven't, as Liz pointed out, you know, the people who come into those programs are people who haven't had a good enough response in a standard once a week or once every 2 weeks sort of therapy, because that isn't sufficient for everyone. And getting the greater intensity of treatment compressed into a shorter time frame is incredibly effective. And if people have that treatment, it's highly likely that they would never need to get to IV ketamine or to TMS or to more esoteric forms of other therapy that might be shifted to. So the details matter. There, you know, I think one thing I've noticed in the psychotherapy world is that people fall in love with therapies, and they do a therapy because they like it. The therapist wants to promote that therapy for everyone they see because they really love the therapy, or maybe it worked for them personally, so they have an attachment to it. But that would, you know, in the medical field, that would be laughed at, right? I mean, nobody would start giving out lithium because they liked it, or say, oh, I'm a Prozac doc, so I give Prozac to everybody because I really like it and it worked great for me. And the number, right? So, and the number of studies and the quality of evidence and the strength of evidence really, really matters. In medicine, there's the FDA. So you don't even cross that first bar of getting FDA approval until there are very large scale, multiple rigorously controlled, placebo-controlled studies done in multiple locations. There has to be more than one or two. There have to be several, and the evidence has to be strong enough so you can present it to the FDA and get approval. And then it goes on the market. And even if it goes on the market, it doesn't mean that it still matches up to the other ones for which there's 10 times more research beforehand. If it turns out to, wonderful, right? And there are shifts sometimes, but you know, nobody would say, oh, I'm a ketamine doc. Well, there are ketamine docs who want to prescribe it for everyone, but in some ways that's malpractice. They're doing that because they have a clinic that makes money by giving ketamine, not necessarily because ketamine is indicated well for everyone, right? And certainly not as a treatment for OCD that would be high up on the list. It would be way down on the list because there's only 2 controlled studies that were positive. So that's comparable to some of the other psychotherapies. Yeah, there might be 2 or 3 controlled studies, but if you take a look at them, they're small, they're not rigorously controlled, there haven't been anywhere near enough head-to-heads with the primary treatments, and they haven't been delivered in multiple populations, in multiple languages, in multiple ethnicities, across the age range, in different comorbidities, or any of that. So the details do matter, and there are reasons why we put some treatments up here and other treatments down here.
Well, that's kind of my final thought, and I'm glad that we had you on today, Sanj, because I will say what I've heard from both advocates, clients, and either other clinicians is that for the first time in a while, it's felt like the wild, wild west. They're having clients come in asking about EMDR or other treatments that are not very studied, or they're having people come in about psychedelics or wanting to get off medications and stuff. And they're just like this. It's never felt like this. Like we've, as a community, really kind of banded together to try to prevent people from getting harmful treatments, because so many people have gone through therapist after therapist and not getting better because they haven't gotten evidence-based care. So I don't want people to hear that any of us on the stream or the foundation or anybody in the community is anti-new. We love new. We want to continue to find other stuff. I find clients really, really, really hone in and find ACT as a successful adjunct. I've had clients that will take Abilify as an adjunct medication, and it's been a game changer. So we're always wanting to do it. I think what we're just saying for those watching today that have OCD or a parent of a loved one is there's a lot of really good research out there that shows the treatment of choice, the frontline ERP and SSRI. Start there and really make sure that you're working with someone who's getting you on the right dose and working on somebody who's doing the right type of ERP, somebody that's trusted, who works in this field, but also the right level of care. And that is going to be, just like you were saying, Dr. Saxena, like working with people on an IOP level and making sure that they have a psychiatrist with the right medications. I refer a lot of people to Liz, but outside of Liz, I haven't had this other that is just like, well, that didn't work for me, right? It's typically somebody who just might not be in the headspace of wanting to do any kind of treatment, but not the treatment specifically. So that's kind of what I just wanted to leave as my final thought is we're definitely open. We want to follow the science. We want the research to guide us, because that always is what we do in the medical and mental health field. So I hope people hear that. Mm-hmm. Want to take us out, Liz? Give us a final.
Yeah, no, it's been amazing. We could go, as you can see, like we could go for hours and hours. We have so many viewers. Thank you all for joining. It's been amazing and fun. And there's more to come, more of this, more discussions around what works best for OCD. What we know is that to date, the most effective and most evidence-based interventions are a combination of medication and therapy. That therapy is ERP. Those first-line medications are SRIs. We hope that you guys learned a lot, and we hope that if you have more questions, if things don't make sense, if you want more content, more specific interventions to be discussed, or for us to break those down, please let us know. You can go to iocdf.org/peace of mind, where you can put in the content questions that you have, that we will make sure to bring in those content experts to answer during some of our next Lunch and Learns. Remember, the Research Roundtable is always the second Wednesday with Dr. Bramowitz and Kyle King, and it's a great time to also ask and get more questions answered for those of you that might have them around, like evidence-based research and what's coming up and what exists and what doesn't. So IOCDF works to put out that content. And then otherwise, every other Wednesday at noon Eastern, we will see you here for a Lunch and Learn or an Ask the Experts. We know there were so many questions. We didn't get to those. So Sanj, hopefully you'll come back and we'll be able to get to all these other questions we didn't get to today. Thank you for your time. This is so helpful. And I know that so many people needed to hear this today.
Great. Thanks so much for having me. Enjoyed it.
Thanks, Saxena. Real quick announcement. I forgot. If you're in the Southern California area, specifically around Orange County, on Saturday, April 6th, we're having an in-person speaker series from 10 a.m. to 3 p.m. Dr. Saxena will actually be there doing a presentation on this topic and going more in depth, as well as part of our Q&A panel. So if you go to ocdsocal.org, we're one of the affiliates of the IOCDF, so ocdsocal.org. If you're in the Southern California area and can make it to Orange County, you can see more of Dr. Saxena on Saturday, April 6th. So definitely come out if you're in the SoCal area.
And if you're in the San Diego area, there'll be another one.
Saturday the 20th.
20th, yeah. I'll be involved in that one as well. So each of these has their own panels. But yeah, I'll be speaking at both on different topics.
Yeah, so it's ocdsocal.org, or go to the iocdf.org and look under affiliates. You'll see, or the calendar, you'll see the events on the official IOCDF calendar. But thanks for hanging out. Thank you for hanging out with us today, and we'll see you back here next Wednesday. Liz and I will be back here at 9 a.m. Pacific, 12 noon Eastern. Take care, and
thanks, y'all. Bye, guys.
Thanks.